Welcome everyone to this Google Hangout discussion on MDG 4, Reducing Child Mortality. My name is Jem Porcaro. I'm the Senior Director of Energy Access here at the UN Foundation, where I lead our Energy for Women's and Children's Health initiative. I have the pleasure to be moderating what I think is a really unique and exciting discussion on energy access and child mortality, and to be joined by two leading practitioners in this area, starting with Michaela Pfeiffer from the World Health Organization and Laura Stachel from We Care Solar. Before we get started, I'm just going to ask both Michaela and Laura spend a minute or two tops introducing yourselves, so that everyone listening in and watching knows a little bit more about you. Maybe, Michaela, do you want to start?
Thank you, Jem. Okay, thanks very much. As Jem said, I work at the World Health Organization. I work in the headquarters offices in Geneva, and I work as a technical officer in the Department for Public Health and Environmental and Social Determinants of Health, where I'm the responsible officer for our work on advancing environmental sustainability in the health sector. So we call that internally greening the health sector. And within that, a big focus area is on promoting climate mitigation in the health sector, and in particular looking at energy and promoting access to sustainable energy. So it's in that context that I joined the discussion today.
Thanks, Michaela. Laura?
Yeah, so I am actually a physician. I'm an obstetrician gynecologist. I was working in the private sector for about 14 years before turning my attention to public health. I started working in Nigeria in 2008 and was really astounded by how the unreliable electricity source was a barrier to good health care, and through those observations began a nonprofit organization focused on bringing solar electricity to maternal child health facilities in the developing world. The name of the organization is We Care Solar, and we bring small solar electric solutions to last mile health centers, and we've introduced these to about 25 countries in about 800 health facilities now.
Great. Thanks, both of you. So before we maybe jump into some questions and answers, I thought I'd contextualize the discussion, spend a couple of minutes giving a little bit of background as to what we're going to be discussing. So since 1990, we know that the under 5 mortality rate has decreased almost by 50%, which is obviously great news, but it's still shy of the 2/3 reduction target under MDG 4. Despite the progress made, we know that preventable disease, premature death, is still plagues much of the developing world and affects children in particular. We know, for example, that about 74 low and middle-income countries account for about 95% of maternal and child death. We also know that about 2/3 of the 7.6 million deaths of children under 5 years of age that occurred in 2010 were preventable. Fortunately, many of the causes of these deaths, premature death among children in particular, are well understood and are gaining a lot of traction within the international development community. In fact, the UN Secretary General has recently outlined a comprehensive set of interventions that are meant to address these challenges within the global strategy for women and children's health, which focus on, among a number of things, really strengthening health systems and services, which is kind of the topic of today's discussion. What's perhaps a little less understood and appreciated is the important role that energy access plays, particularly among health facilities, in strengthening health systems and services, and especially for children, who often bear the brunt of inadequate primary care. So I wanted to kind of tee up the discussion with that in mind, but also acknowledging that as we know, energy access has a number of touch points on children's health beyond just primary care and health facilities, including exposure to indoor air pollution as it relates to the domestic use of energy. So acknowledging that there are a number of touch points between children's health and energy, I'd like to kind of maybe pivot and focus a little bit on the impact that access to energy has in health facilities as it relates to children's health. So with that as background, I just want to kind of get things started by asking both of you a couple of questions. And maybe I'll start with Laura. And Laura, can you tell us a little bit about kind of why is energy access so important to health facilities and to reducing child mortality? Can you give us a couple of concrete examples of those linkages? Really, how does the availability of energy enable the life-saving health services that are required to reduce child mortality?
Sure. So I think it's really important to step back and think for a moment about all the ways that energy and electricity in particular are really crucial to life-saving care. I think any of us who have access to a hospital in a developing country would never imagine for a moment going to a hospital that was completely in darkness, unable to use any of their equipment, unable to even have enough light to locate a medication that could be life-saving. But indeed, in many parts of the developing country, primary health clinics as well as hospitals do not have reliable access to electricity. Many rural facilities have none at all, and hospitals that may have access to electricity for some of the day may be plunged into darkness for 12 hours a day and sometimes weeks at a time. So what that means is that a hospital may be completely in darkness. It may mean that emergency cesareans that would be there to help to save a newborn's life cannot be performed because there is no light, there is no power to clean equipment, there's no power to use other types of equipment in the operating room like a suction device or a cautery device. It means that diagnostic equipment can lay dormant like ultrasounds, like microscopes, like other types of laboratory equipment. And in having spent time observing in a pediatric ward, it can even mean something as basic as a nurse not being able to see the very children she's charged to care for. She may not know when that child is due for their next medication. She may not be able to see their arm to start an intravenous line to provide life-saving fluids or medications. She may not be able to read the bottle of medication to know what there is to give if she needs to give medications at nighttime. And I've actually witnessed situations where life-saving care is postponed until the next day, as the nurses say, until the sun comes up, because there just isn't enough light to perform care. So I think light in one sense is probably the most crucial, but think about all the other devices, both for diagnostic and therapeutic care, that are really essential on a day-to-day basis that depend on electricity. And then finally, one of the largest killers of children is infectious disease, and there are many infections that can be prevented by vaccines, and vaccines require refrigeration, and refrigeration requires electricity. So you're both talking about immediate life-saving care as well as preventive care that is severely affected by energy restrictions.
Thanks, Laura. Very comprehensive. Mikkel, I don't know if you have anything else to add, but if not, I'd love to get your perspective on kind of what's the state of play now, having heard how important access to energy is for providing these health services. But what's the state of play? We know that WHO has done a lot of good work in trying to understand to what extent health facilities, health clinics, hospitals around the world have access to energy. Can you maybe talk a little bit about to what extent, what's the state of play of access to energy among health facilities?
Okay, all right. I think the first thing I need to say, though, is that, in fact, while there is a big effort underway to clarify and to assess the state of the problem, there are some very significant limitations in data availability. So I need to say that as a caveat. But what I can say is that what we know, for instance, in some of the most resource-constrained settings, which also happen to be some of the high-burden settings for maternal child health mortality, in Africa, a recent survey showed that as many as 58% of healthcare facilities lacked access to electricity. 58%, that's quite a staggering number. And a further analysis of 11 countries in sub-Saharan Africa showed that on average only about 34% of healthcare facilities actually had reliable electricity. So you can imagine the energy poverty situation is quite extreme in many of these settings. So that's just sort of a snippet of what we have in terms of the available data on access or energy poverty in some of the most resource-constrained settings. But I can say that what's happening as a result of our need to really further quantify the problem, there's quite a big move now to look at enhancing some of the existing survey tools that WHO is using. For instance, the WHO, it's called a Service Availability and Readiness Assessment, or otherwise known as the SARA, which is the tool used by countries, by health systems, to do a diagnostic of the state of readiness of their health systems for delivering care. And within that, we are building an expanded module to look at this issue of energy access, as we see that it is a very critical determinant of both the availability and the quality, as well as safety, as Laura pointed out, of essential health services, and in particular for maternal child health services. So there is quite a bit underway in terms of documenting and really quantifying the state of the problem, but the little data that we have shows that there is quite a significant issue.
And Michaela, would you say that is it fair to say that the hotspots for this issue correlate well in terms of where you see low energy access among health facilities? Is that also where you see low maternal mortality and children's health indicators? Do those correlate well?
They do correlate quite well. It's not necessarily 100% match, but the high burden settings, yes, they do correlate quite well for where we are getting the data. Although I will point out, and this is another scenario where energy access in healthcare facilities is also of significance and equal importance in many ways, is in a setting where you have a significant disruption to the system. So although it's a bit side to this conversation, I think it's also important to remember that energy access, when disrupted, for example, in the context of a disaster or in a conflict situation, is also a critical concern. And we have lots of examples, and I know, Laura, you were there in the Philippines visiting some of these facilities and can attest to the fact that you can also have really important power problems in those types of disruptions and settings.
Thanks, Michaela. Maybe that's a good segue into kind of another line of discussion, which is, so we know the issue is important. We don't have all that much information and data around it, but the data that we do have suggests that there are still large pockets of health facilities that lack access to and reliable energy. What are some of the barriers that both of you are seeing in terms of increasing access to energy services, or I should say energy-dependent medical services in health facilities across developing countries? Michaela, maybe do you want to start this off and kind of mention a few from the perspective of WHO as to what you see are the key barriers to expanding access?
Sure. I think lack of sufficient evidence about what works and what doesn't work is one of the barriers that we're encountering, that there simply isn't a solid enough understanding about which types of energy solutions would be optimal given certain combinations of service packages or given combinations of demand. So the lack of baseline evidence around what we could do to address the gap is a bit of a barrier. But it's one I know that we're working on, but it is a barrier. The other is that I think, in my perspective, I think that the issue of energy access is not really yet central to the way that the health sector is formulating and planning its service delivery packages. When you look at some of the safe and green hospital indices, or when you look at sort of quality of care indices, energy and access to energy or access to electricity is typically looked at as an operational or an infrastructure issue. It's not often linked to the quality of care. So if there's an evaluation of the quality of care, which may look at, do you have skilled workers? Do you have the right medical devices? Do you have the right medicines available? The energy equation is not often coupled with that, and I think that is one of the issues. And it could be that there is this sort of classic kind of siloed approach where energy is another sector. It's an infrastructure issue that's not fully within the remit of the health sector to control. That may be one of the reasons why, but I do think the fact that energy is sort of peripheral to the way that the health system is evaluating its own performance is a barrier that we need to address. Right. Another barrier is a pretty critical one, is as we start looking towards other solutions and options for addressing energy gaps, is to look at the medical devices themselves, and the fact that we have a very, very high rate of medical device failure in low income settings. And a big part of that is because they're not well paired with the energy realities of those settings. So there is need for really looking into the types of devices that are being promoted, being used in those types of settings to make sure that they're fit for purpose and that they can function given different energy scenarios, but also given different energy technologies. And Laura, I'm sure you can talk about that and how you relate different devices to solar panel, for example. So the fact that we don't have good matching between the energy needs of medical devices and power circumstances is another barrier. I think I'll stop there. Those are a couple points.
I can also add to that list. I think it is a cross-sectoral issue, and I think you're right, Michaela, that when the health departments are sort of thinking about healthcare in one silo, and energy seems to be to the side of that, and it's really important that we create more cross-sectoral solutions. I think also where energy poverty is the greatest are countries where infrastructure in general is really a problem. I mean, even the roads getting to these places. Are there reliable supply chains for medications for these places? And so then thinking about reliable electricity is yet another problem on a system that already is facing so many barriers. I think that initially there probably were more attempts to think about grid electricity reaching rural health clinics, and I think more and more now that we have renewable solutions, we think that it probably is more practical to think about distributed energy solutions, because the grid is probably never going to reach a lot of these last mile health centers, and even if it were, there are so many problems with having reliable grid power that it doesn't even create a fully reliable solution. I think the issue of medical devices is also very important, that well-meaning donor countries have sent lots of energy-guzzling equipment into third world facilities that will never have the energy to power these equipment. As an example, I remember in this first hospital I visited in Nigeria, a huge, beautiful ultrasound machine that used so much energy, and it was sitting in pristine condition in a closet because there wasn't the power to support that machine, and it required, this was several years ago, $25 of fuel for just 5 minutes of use, and so it wasn't really a practical solution. So thinking about how we can create more energy efficient devices that can work off of the power that will be available to these facilities is really important. And I just think logistics and finances are really a huge issue. Most of the countries where these problems exist are really dealing with very tight budgets, and so it's very hard for people to balance what do they spend that money on. Do they put it into energy? Do they put it into the vaccines when you're already making huge trade-offs to begin with? So I really think that the world should be standing up and taking notice, and we need to say, yeah, energy is important. Energy in a health facility is part of a basic right to health care. And I think until we get international attention, we may not get the finances that are really needed to address this properly.
Right. Thanks, both of you. I think something that both of you mentioned was the opportunity, the option that off-grid technologies like solar PV provide in terms of providing some basic services to health clinics that might not otherwise have them. Laura, I know you've spent a lot of time, working in clinics in country. Can you tell us a little bit about your experiences as it relates to some of the challenges in maintaining these systems? How important is maintenance as a barrier to ensuring that these systems provide these services on a sustainable basis? Can you touch on that kind of more practical issue as well?
What's kind of interesting is that these are impoverished countries, but they actually need the highest quality electric systems. Whatever the solution is going to be has to be one that is high quality, because these places are quite remote. They're very difficult to reach. They need to be easy to maintain, and they need to be affordable to maintain. So I've spoken to people, for example, in clinics in the DR Congo that were given a generator, and they will never be able to either afford the fuel for that generator, afford to fix it, or even have access to getting fuel on a reliable schedule. So we really need to think about the whole ecosystem involved before we put any type of energy solution. So if you're going to put something in place, what are going to be the additional structures in place to make these things affordable to maintain, easy to maintain? Who's supposed to be budgeting for that? I've already forgotten the question.
Well, you're touching on it. These are all the kind of the key issues one needs to think about in terms of...
Oh, and then there's education. That's another part of it. So a lot of times when we've gone into clinics and seen prior projects that may have failed from other organizations, there really wasn't the capacity building locally. So there weren't people that were both championing this that understood the systems. And so I think building local capacity is really important, and that means education. So if we're going to use renewable energy solutions, there need to be local experts that really can take ownership, that understand how to use it, and there needs to be the supply chains to give people supply parts for it. And I'll tell you, one of the biggest barriers that we find is the cost of transportation to these systems. So sometimes, like if we have a very small part that needs to go to a facility, it can be several $100s to pay for the vehicle, the driver, and the time for someone to go and bring something there. And that's where, in my opinion, it's really important for the health sector to say, hey, this is important, and to piggyback different types of services together. So if you know that medications are being brought to a facility every several months, then those are the times that you bring in the supplies to help support the energy system as well, that you do these things in concert rather than having duplicate, parallel, expensive pathways.
Great. Thanks, Laura. You know, you mentioned taking an ecosystem approach. I'm curious to hear from both of you. It's a related issue, and that is, you know, what role does energy access have in helping attract and retain qualified health staff? So not so much in the sense of providing the services at the clinic, but as a way of ensuring that qualified staff are actually attracted and retained within these communities. Can you touch on that, maybe, Michaela? You know, what's your experience from WHO? To what extent is that really a big key issue for this area?
I think there is a very clear correlation. I mean, you can think about it logically. In one level, if you have power, you are able to offer a different array of services. In some instances, you can offer even more sophisticated services than you would be able to in the absence of power. So there, in and of itself, you need qualified people to be able to run the services. So you can attract and draw qualified resources in that way. But also we hear anecdotal stories of how having access, well, there's safety, people feel safer there, it's well lit, they can watch TV, they can, you know, there are things that they can do within the health center, so they can do learning after hours, you can make it into a hub of, you know, continuous training. If they have access to the internet and communications, then they can interface, and you can have all kinds of opportunities for exchange and for you know, e-medicine. So there is a very clear linkage between the attractiveness of a healthcare facility being more functional, being safer, having more diverse things going on, and the retention of health workers. At least that's what we've been seeing.
And I can totally corroborate that by having spoken to health providers before and after, having access to electricity in their facilities. They absolutely tell me they no longer fear coming to work at night. But I think I'd like to tie that back to our original focus, which was on child health. Patients are also much more likely to come to a health facility that is well lit at night and that has a health worker who's not going to be screaming at them saying, why didn't you bring a candle with you? Why didn't you bring money for kerosene? I had no idea that in addition to all the other barriers that poor women face getting care, that one of the barriers were that there was a whole interchange with midwives about who was supposed to pay for that inadequate source of light at night, whether it's fuel for the kerosene lantern, fuel for a diesel generator, or candles, or batteries for a flashlight. And so once the community realizes that lighting and electricity is short in a facility it increases the uptake of skilled care. That uptake of care is essential to bringing women into facilities during the moment of childbirth, to bring families in when their children are sick. And so if you're going to be addressing these preventable causes of death, you do need to get people into the health facilities. So I think we should remember that happier health workers also translates to better care at night, which translates to healthier communities.
Well said. Thanks, Laura. Very good point, both of you. We probably have about 5 minutes left before we wrap up, so I wanted to kind of transition the discussion, and we're already beginning to highlight some of the opportunities, some of the options for addressing this issue. Are there any kind of lessons learned from initiatives, programs that are trying to address this? Are there any kind of quick wins that the two of you think that the community ought to be focusing in on in the short term? What are the success stories? What are the things that we ought to be kind of looking at in terms of moving the needle as it relates to this issue?
Well, I personally think solar power has a lot of promise. That's why I worked with my husband to create an organization to dedicate to this. I think that a lot of the countries that we're talking about where there are hotspots of high maternal and child mortality and low electrification are along the equator, and so there's usually an abundance of sun, and so I think utilizing a free source of fuel is something that makes a lot of sense. In our case, we ended up focusing on a fairly compact amount of energy that's in a kit that can be easily installed, easy to maintain, and much more affordable than large systems. To be perfectly honest, if I had all the money in the world, I would love to put large, extensive systems in every health facility, but I don't think that the finances are there right now. And so choosing interim solutions where you can provide that first, what we call it is the first 100 watts for last mile health centers, can make a sea change. It can mean that a midwife can see during a delivery and create a safer delivery. It means that if an asphyxic baby is born, a baby having trouble breathing, she can see that baby. She can provide the initial care to help that child to breathe. It means she can start an IV if it's needed. So even though it doesn't cover everything, it can be a very critical bit of energy. So in our sense, as I said, we've brought this to more than 700 health facilities now, and the reports that we get back is that it's very transformative and that it is attracting more people to utilize health centers. And so I think that's a quick win right now.
Thanks, Laura. Any final thoughts, Michaela, in terms of where, from your perspective, where you think the priority ought to be in the short term? Any quick wins or success factors that we ought to be focusing in on?
I think we have a massive opportunity ahead of us with the Sustainable Development Goals, and with the fact that now there is this sort of refocusing of attention on what is sustainable development, refocusing of attention on how are we going to deal with this problem of climate change. And I think that that opens up a massive opportunity for the health sector to position within that, really around this issue of sustainable energy, tapping into alternative, cleaner, more sustainable energy solutions to promote and address its issues, such as what we talked about today, but also more broadly, that the whole goal, furthering the goal of universal access and universal coverage, and how we're going to meet that, and how are we going to meet that in the context of a growing non-communicable disease burden. Now, I know this is a bit off track, but it's related in the sense that we know that the demand for medical devices for services, for services and for the types of services is increasing, particularly in these resource-constrained settings. We're going to need to have radiology therapy in these settings so that cancer patients can get screening and can get treatment. And the power implications of pushing out that kind of technology to these settings has huge implications. And I think that the health sector has it's at an important moment where it can really pivot itself and it can harness that opportunity by getting into this area and really taking advantage of that. But in order for that to happen, as I said before, I think the issue of energy access and energy poverty needs to be a bit more central within the way that the health sector formulates its plans, formulates its strategies. It needs to be a core pillar within its Every Woman, Every Child initiative. And so in order for that to happen, this is where we're at. We need to be raising awareness, advocating, and helping them understand how to position that.
Well, I think that's a great segue to also mention, as both of you know, the UN Foundation, WHO, and UN Women are now co-leading a new initiative under the Sustainable Energy for All initiative, which is a global platform led by the UN and the World Bank to promote energy access, renewable energy, and energy efficiency. Under that platform, our three organizations are now co-leading with a number of other partners, including Laura and others, an initiative or a high-impact opportunity area which called Energy for Women and Children's Health. And this is precisely the goal of this effort, is to try to mainstream this issue within the health community and vice versa, bring attention and focus to this issue and hopefully drive change on the ground. So maybe with that I'll kind of wrap it up and say that I think this is a great conversation, some real-world examples of why energy access is so critical to providing the health services that are required to reduce child mortality. It sounds like there are a lot of opportunities to move the agenda forward, and in particular this new Energy for Women and Children's Health initiative that we're all involved in and will be moving forward. So I just wanted to thank the two of you for joining me today on this discussion, and obviously everyone else who's watching in and listening. I hope you found it informative, and thanks again. Take care. Bye-bye.